Now I'd like to ask if you don't mind remaining here on stage, because we will continue with this expert panel session talking about longevity too, and the new standards of care for the future, and how to provide care in a community and home environment. That's why, if you don't mind joining you, we'll also have here, and let's receive on stage Nuno Santos Lopes from Nightingale Hammerson, and Walter Coffey from the Eden Alternative. Thank you very much for being here. And of course, this session will be chaired by Marco Inzitari from Parc Sanitari, Pere, Virgili. So
let me give you another.
We have you here. Oh. Thank you very much, Marco.
Take one for you. That one is for you.
Thank you.
Do you need? No,
I don't need it.
Okay.
At least not myself. Thank you. Thank you to the audience for be with us until, let's say, relatively late. We are behind with the schedule, but I really enjoyed the presentation by Eloy, such an inspiring talk. And I think we are going to discuss a bit the points that he highlighted. I think we have a big question, which is for me, why? How could it happen that after 17 years of Hogeweyk and other experience in the world, we are not there with all our, let's say, structured nursing homes and places for people with dementia? So I think that's, let's say, the big question we have. But with the other two panelists, after the Eloy's talk, we would like to know which are their experiences, which are their backgrounds. So our idea for this panel is to let them, Walter and Nuno, to tell us in 4 or 5 minutes which are their experiences, and then we will discuss in a group discussion with the short questions and answers about the model and where we should go to have this model implemented everywhere. So, Walter, you like to tell us who you are, what you do, and then...
There you go. So, let's see. There it is. Okay. So thank you for hanging in today. There's been a lot of really good information. I was so taken with the opening and how all this stuff fits together, because I was taught the aging process starts the day that we're born. And so it ties to really everything that we're doing. And one of the things that we know is that over the years that elder care and housing was designed after hospitals, and it was that medical model. And we all agree that the medical model is not the one that we want, that institutional model. And we know that it skewed providers' care and providing care for older people. So the biomedical model is, as you know, where a person is seen as a patient. And in most nursing homes that I've gone in, they still call residents patients. They talk about the facility. Nobody lives in a facility, like you were explaining to us. So all these things are starting to happen. And so immediately, we realize we have to create a balance, that things are out of balance. It's like we did the medical part really good, but now that's what we're stuck in. And so what is the balance? And that's nurturing the spirit of older people as they get older. So patients become residents, facilities become home, and all these things start happening. The words that we use that don't cost anything are so important to change our consciousness and move away from the way that we think about doing things. So we have to change how we feel and think about aging. And it's not easy to do. But what we always do, and what we've done in the United States and starting this culture change movement in our state of Georgia, is to say, what do you want for yourself and the people that you love? And how can you just take it back to the humanity part? Because after moving to Spain, it's like, oh, our culture, you have to understand this. And then we spent time trying to help in Moscow, trying to help them figure out how to do housing for people that were growing older there. And it's like, well, our culture, da-da-da-da-da. But it's always like, how can we go back to human beings? Let's just think about what do we want for ourselves and what do we want for the people that we love. And it's always a great place to start. And so a lot of times when we would go into nursing centers, senior residences, we'd say, wow, this is interesting. We would think that we were going into a hospital. Looks, smells, acts like a hospital. Everybody in there is running around in white coats like they're doctors. The staff have scrubs that look like they're going into surgery. But yet people are supposed to be living there. And so it's like, wow, would you like to live here? And guess what people say? Not no, but hell no. We don't want to live here. Nobody wants to live here. This is awful. And so it's like, well, what would have to change? What would have to be different if you were to live here? And then you start all of a sudden getting into, well, these are some of the things that might be different. So from the Eden alternative, I'm going to share some of the aspects of the Eden alternative just so you can get a feel of what it is and how it works. And everything that we're talking about when we realized on our call is all tied to being healthy and brain health and all the stuff that we've heard all day long. It's amazing how it all really connects. But from the Eden perspective, it's nurturing the spirit of people as they get older. And we're really starting to say person-directed living. What does that look like? And we say ACP, person-centered care and all that stuff. But Eden is a very adaptive, it's a principle-based philosophy that really provides an approach to putting 10 principles into practice. And then every community and organization uses 7 domains of well-being and warrant surveys and different things to guide them to develop their own pathway. But what makes this an alternative that we know that really works is that it's not a cookie-cutter program. And I can't tell you how many times I've seen people say, you can get a certificate in ACP, person-centered care, and all that, especially in the Southern European countries. And it's a little program, and you do 1, 2, 3, 4, 5, and boom, you're person-centered. But people don't learn anything. They don't realize that it's an approach. The Eden Alternative is an approach that helps people think about how to be person-centered. It's been around 30 years, started in the United States by a Harvard-trained geriatric physician. A lot of you know his name, Bill Thomas. It's now in 20 countries. We are trying to, moved here to retire 7 years ago and started getting asked about Eden Alternative because I did a lot in the United States over the last 20 years on transforming organizations, a lot like what we just heard about how you really make this happen and focus on it. And so we decided to see if Eden could be of interest here. And there are several people in this room that are very interested in Eden and are trying to figure out how to make that work. But what Dr. Thomas said is that even as a physician, he realized that the medical part just didn't hack it. It's like where people are, just as many people are dying of other things, because he identified 3 things, because people are lonely, they're helpless, and they're bored. They're experiencing these things. And so to nurture these experiences, we need to make sure that we have close and continuing relationships to address loneliness, that we provide opportunities for people to give and receive. We hear about caregiver, and people just sit there and receive. But it's like, how do you have a care partnership where people are still giving and receiving and they're not becoming helpless? And then how do we alleviate boredom by making sure there's variety and spontaneity in a day? There's so many times when we go home at the end of the day, we may eat our dessert, we may go for a walk, we may not do anything, we may just get into bed. But we have that spontaneity and ability to do that. So These 10 principles are learning about kind of what they are and how they work, but there's some practice principles and some drivers. And the practice principles talk about eliminating meaningless activity because it corrodes our spirit. To make sure that we redefine care. Sometimes we think about care as medical treatment, but there's more to providing care and receiving care than it just being medical. And that is fostered by really knowing people and having deep, meaningful relationships. And also to make sure that people take the lead in their everyday decision making. What's going on for me? What do I want to do for today? And to make sure that the drivers are in Eden, and to make sure that you realize it's an ongoing process, that you're always learning and growing and adapting. And then wise leadership. And this is not only leadership in the corporate ownership level, government level, but people that are leaders in the organization making that happen. So I skipped a slide. I was so entertained by that. That's those.
Like a short more.
Yeah.
And your part, and then we will skip to Nuno.
Okay. So there's warmth surveys that help people know how warm they are, and you can prioritize the things that go good, work on the things that aren't. There's transformation, 3 areas of transformation where you have to have the personal first, where you have to really be passionate about what you do and realizing it's a human right for people to experience quality of life. And so the trick was, I think we'll get to it in the questions maybe, but is empowerment, is making sure that the staff are empowered to make decisions with residents on a daily basis. And that's kind of the secret to making all this happen. And when these things happen, staff satisfaction goes through the roof, the residents are happy, everybody's happy, people stay longer, and we maybe can talk about the data after 2.
Perfect, thank you, Walter. So we will ask Nuno the same question. He comes from the United Kingdom, and maybe can introduce us shortly what he does there and what this institution does, and then we will go to the round questions.
Perfect. Thank you. I have to say I'm not surprised that when Eloy asked the question, does any of you want to live in a care home when you get older? Nobody raised their hand. I'm not surprised at it. That's why at Nightingale Hammerson over the past decade, we have started a process to try to demedicalize, deinstitutionalize as much as possible our care. Our mission at Nightingale Hammerson is to deliver care to the older Jewish community. And for that, we've got 2 care homes, Nightingale House and Hammerson House. Both of the homes are based in London with capacity for over 100 residents each. And we provide all the levels of care you can find in a care home for older people. From residential care for people that are fairly independent, and we provide more hotel-type services, to people that live with early stages dementia until end-stage dementia. We also provide nursing care for people that are cognitively well, but are unable to do things by themselves, so we are their hands and their legs to provide the care to them. And we also provide respite care, rehabilitation, and we are very proud of the palliative care we provide across our homes. We, every year, look after around 70 to 80 people that die under our care. So, in terms of the future of care, we have been existing for over 180 years as an organization. But what we have seen is that in the past 10 years, when people are moving into a care home, they are moving at a much later stage of their life. So while before the majority of our residents would walk independently when they were first coming into the care home, the majority of them come now at least on a wheelchair, or if not, they come on a stretcher directly from hospital, which means people are living at home for longer. So we started thinking as a charity, how can we start reaching those people and the ones that look after them to be able to support them before they need our care. For that reason, we started the new initiative, Reach by Nightingale Hammerson. And with that initiative, we are creating content, practical advice content, that is freely available in our YouTube channel that you can scan the QR codes, where we are using the expertise from our occupational therapists, from our physiotherapists, from our nurses, to give advice to people on things like, how can I assist my mom to get in and out of the car when she has mobility issues? How can my mom continue to eat independently if she has Parkinson's and starts struggling? So how can I adapt the cutlery for her to still be able to eat independently? How am I going to engage with my mom if she lives with dementia and she's asking me 10 times the same question in 5 minutes? What can I do to prevent the distress from her and to keep her engaged? So I'd invite you to visit, comment, and subscribe to our channel. The most recent video that we have released was done in conjunction with a palliative care consultant, and the video is about what is happening when someone is dying. People don't like to talk about dying, but we are all facing death. So what is normal when someone is dying? And the normal, as Eloy say, is not to be with a feeding tube when someone is dying. Is what is the natural process of dying looking like? So this is just the introduction, and yeah, I look forward to questions.
Thank you, Nuno and Walter. So I will start with a question I was referring to before. So it's been these are not new experiences. They have been there for decades, I would say now. So how it's possible if all of us would live in the Netherlands, in the dementia village and in other places, how it's possible that we are not there everywhere? So what should we do, I would say, at the political level, at organization level, at the professional level, even at the citizens level, to change our mentalities and to really change the way of providing care in a holistic sense. So maybe, Eloy, can you tell us from your experience which would be I would say the three things, so the first three things that you would do, or what do you think we should act?
Yes, and so Spain is not the only country. Most countries, including the Netherlands, are mainly still more traditional models. Maybe the Netherlands is a little bit a front runner, but are still very traditional institutional organizations. So you see that change overall is very difficult for everybody. Change to electric cars is very difficult, for example, other topic. Change in another model. And I think that the medical model worked for the older people now, but the modern new people will not accept anymore the more traditional care models. If you don't raise your hand that you want to move to that structure, you need to change. And that's the good question, what do you want for yourself? This change is difficult, and I think, like in the Netherlands, we need examples to show that it can be done, because people think you cannot do it with the existing regulations. I think you can. People think you cannot do it with the existing financial model. You can. We did the same. And the other initiatives I showed you were all the first in their country. They did the same. So it's not about money, it's not about regulations. It's about that we, society, need examples to show what, in this case, people with dementia, but it's for all older people and people in general, what is possible. So we need to work on examples. That's the way the transformation starts.
Walter, do you think that we should push more, or how can we reach the politicians or the administrator to change our policies and move towards the new model? Maybe it should be more progressive or more sudden. I don't know. What do you think about?
Yeah, I think that people don't realize how much structure and regulations and all that stuff are in place until their mother is moving into a senior residence or something, and then all of a sudden, oh, she likes to sleep late, but you only have breakfast from 7 to 9, or she likes a bath at night, but you only give showers in the morning. There's all these things that are created to support the organization and not the person. So it's organizational focused, right? Centered, not person centered. And so it's starting to, when you start asking the question, would you live here? And they say no, then what would have to happen? Well, I want to go to bed when I want to. I want to wake up when I want to. For me, when I get up, I want to have coffee only, and then I may want to eat 30 minutes later. And so then you have to make sure you have relationships with regulators, with the inspectors, because all they're doing is going by a checkoff list. But when you start saying to them, you know, what if your mother lived here? Or what if you needed to live here? You know, what could be different? And how can we start looking at human beings and not housing people in hospitals? And then all of a sudden they start thinking about that. And this, the simple pleasures that you talked about are really great. And when you realize I've got these 7 simple pleasures that I love, but all of a sudden when I move here, I only get to keep 2 of those, well then that's a problem for people's quality of life. So how can we give those simple pleasures back? So it's creating relationship.
So we should put together, I understand, administrators and inspectors and so on with people and make them understand which are the preference of citizens, let's say, towards a new model. And Nuno, what about professionals? I mean, do you think that we should start from the training level, grades and whatever, to make professionals understand that it's possible to work in a different way? Which skills do you think we should teach or we should share with them? Maybe if you want to also pop in and add your point of view, you are free to do it.
I totally agree with that. You know, the way we are training the professionals also needs to have or needs to include social care settings. One of the big drives we are having in the UK, for example, with the nursing training, majority of nursing training is happening in hospital. All the placements happen in hospital. But we know there's thousands and thousands of people that are being looked in social care on a long-term way. So how can we, and one of the biggest drives from the government, quite rightly, they've woken up now, is to transition care from hospital to the community. Why? Because it's long-term, it provides better quality of life, and it's much cheaper. So if we get the professionals to experience what social care is like, it's more likely when they decide where they want to practice their nurses, they will come to us. But at the same time, they also understand that in a care home, for example, the rules are not strict as in a hospital, because a care home, is the resident's home. And that will help us then to challenge the status quo in things like, you know, as Walter and Eloy described, you know, the regulations are there and they are helpful, but doesn't mean you need to be strict with them. And we cannot expect to have the creativity coming from government. No.
Right.
And from the inspectors. No, they are not creative. They go with what is written in there for them. We are the ones that need to be creative. We are the ones that need to challenge them and say, your regulations are not right. For example, during COVID-19 pandemic, we were depriving people of their liberty on a horrible way. How could you have someone for 14 days on isolation in a room that is smaller than this stage, and more when you have someone living with dementia? You know, that was imprisoning. Or when we had to be wearing masks, imagine in London, we've got people from all over the world, we all have different accents. Residents at old age, they are more likely to have hearing impairment, with cognitive impairment, a mask in the middle. Communication was hell. And the distressed behaviors from people living with advanced dementia were growing, which is normal, because they couldn't communicate. So we decided, despite the regulation from government, we did our risk assessment and we felt it is going to be safe not to be wearing a mask. and we removed masks from our home. Funny enough, the number of COVID outbreaks diminished, and main thing, the quality of life of residents and our team members improved significantly. That costed us an extra inspection, but at the end the inspector came and said, well done, you are taking a person-centered approach, it's safe what you are doing, carry on.
So people need examples. Politicians need examples. And so what works in the examples I showed you in Australia, New Zealand were the first. And so they did a pilot. They asked permission to do it a little bit different. And so the example in New Zealand asked permission for 5 years. And there was research done by the university, and it was proven that the quality was better and it was financially feasible. And so then it was embraced by the system. So we need examples. The Hogeweyk was an example for the Netherlands. And it took 20 years. So we need to have a little bit patient, but we need to have examples so people can feel it, see it, and then maybe the regulations will be adapted to the new situation.
So we have the first part of our recipe. We need example, of course, maybe starting with pilots and associated to research to really make sure about the impact and also the economic evaluation. That's one part. We need to bring together administrators, politicians with people and citizens and make them understand what really people want. And we need to train professionals not only in the usual hospital setting or healthcare setting, but also in the community setting and in the social setting. So please write down, and that's a very valuable contribution so far. I'd like to ask Eloy and also the rest of the panel. So you showed, let's say, an idyllic scenario where everything works and of course, is a success story. But in your journey of 17, 20 years, I'm sure that you found things that didn't work, that you would do different, barriers that you had to overcome. So what would, tell us about some of these, let's say, failures that you might have experienced in your journey, and what you would recommend not to do to someone who is starting to implement this model shortly.
Failures are some simple examples that the bridge I showed you went too slippery in winter, even very quickly. So that's a very simple example. What I would like to do now is not design for dementia only. I would not say it's a failure, it's a decision we made in time and we learned over the last 20 years. And we came from a nursing home, and we are still a nursing home specialized in dementia care, but people with dementia benefit, and it's much more normal if other people live in the neighborhood as well. So I would like to add other people, children, other people living there, creating a more dementia-friendly neighborhood for everybody. We based the model on small group home living. A small group home for 7 people is very successful. There's research that proves that it works better than a big ward for most people, but not for everybody. So I would like to add different housing options to the Hogeweyk, where people with dementia, advanced dementia, cannot stay at home in their own house due to reasons and the burden of the informal caregiver. But in the neighborhood, they can still thrive. So different housing options. And we are working on opening the door of the whole neighborhood. So it's still a sort of secured neighborhood. And 20 years ago, the government said, you need to have a lock somewhere. So you cannot just walk in and out, everybody. Some people can, some residents can. But we have to unlock the neighborhood, which is scary for family members, scary for care workers, scary for the organization, but we have to unlock the neighborhood because we cannot lock in people with dementia against their will. It's inhumane. So that's a lesson learned, and that's the next step as well. So the Hogeweyk is opening, and we are piloting. We unlock the door nothing special happened. So that's the next step. Unlock all dementia, nursing homes, wards, units.
Thank you. Walter, in your experience, what would you recommend to some managers or entrepreneurs or administrators that would like to change their model to this new EDM model? So which are the barriers they might face and which might be the ways to overcome these barriers?
Yeah. I think for me, it's one of the things is understanding the difference in delegating things and empowering staff. Because what we now know in person-directed living and person-centered care, the staff have to be empowered. And there's a process of doing that. You can't just say, you're empowered to do everything with the residents today. But they have to have the skills and the training. There's a knowledge level that has to happen. There's a sharing of information. There's making sure that the resources are there. And there's the creating the environment to say, we can do this, make it happen. And what happens when staff are empowered is that the managers and supervisors aren't overstepping and getting into everything because they're able to let go of it. When somebody's empowered, you let go of it, and then they have more time to do their work, and they're happier. But just think about if a resident wants to do something, and they ask a carer, a person that's touching them and helping them, can I do this? Can I wear this? Can I eat that? And the person is immediately empowered to say, yeah, let's do that today. Or yeah, let's eat this today. Because they're empowered to make that decision instead of saying, well, I don't know, I have to ask the supervisor, or maybe we can do it next week. But when people are empowered, their satisfaction rate goes through the roof. And so they want to stay with the organization that has empowered them. The residents' satisfaction goes through the roof because they're getting what they want. They're being listened to. They're directing their daily activities and what's going on. And of course, if the resident's happy, then the family's happy. So all of a sudden, the satisfaction rate goes through, and you're not replacing staff who continually leave to try to make more money somewhere else, or because they're not being listened to, because they're not able to take care and provide care to somebody like they would their grandmother. And so, and it has financial implications, like we were talking about in some of the sessions this morning, is that when you're not replacing staff and everybody's happy, your occupancy rates are higher. So you're able to do more, and you're able to have more money flowing in and all that. So to me, the empowerment is the secret to making all this happen.
Thank you. And Nuno, in your case, which are, I don't know,
Do you want me to talk about mistakes?
Yes, please.
Fine.
Mistakes and barriers, please.
I don't have enough fingers to tell you how many mistakes we have done this year so far. So we make mistakes every day, almost.
We as well.
Fantastic. That's
It's
why
not
we
perfect. It's
can.
never perfect.
That's why we can move things forward, right? We have mistakes. The most serious ones was to hire the wrong people. To hire people that do not fit with the culture, that's a very expensive mistake. And more when those people are at a senior level. So take your time to recruit the right people. That's what I'd say. And I know it's difficult to recruit now people mainly to the care-related work, but to have the right people will, first of all, provide much better service. As a manager, you'll be much more relaxed. And as you talk about occupancy, the quality of the service you provide is going to be better. So other mistakes we've done, technology. We've implemented technology and removed. Those were expensive mistakes, I have to say. But we trialed, and we are now trialing a new technology to try to assist and provide better quality of life to our residents and better assistance to staff. But one of the things, and because with technology, mistakes can be quite expensive, the first thing, or the main thing I've learned is make sure your requirements are clear. What is the problem the technology is going to solve for you? No, don't just put technology because it's trendy or because you think it's a good idea. What's the problem you want to solve, and how is the technology going to help you to solve that problem? We've done the Care Home Research Forum 2 weeks ago at one of our homes, and one of the guest speakers was talking about implementation of technology in care homes. And actually, on her findings, she found that on the medium term, technology is not giving any benefit. It's actually generating more work. In the long run, yes, but we need to have into consideration the implementation phase. And it's about, we need to learn the system. The service users need to learn that they are living with the system. We need to be able to get the data. We need to be teaching all the staff on how to use the system. So technology, yes, but think the question you want to answer with the technology.
I would like to add to both that, and you mentioned it, but you didn't use those words, that a clear vision, what do you want to achieve for management and therefore also for staff members, if you want to empower them, they all need to embrace the same vision. The success factor, I think, of the Hogeweyk is that we had the same vision for 40 years. It's 30 years, I think. 1993, it started the vision, a normal life for people living with dementia. And in all the management decisions we made at the table, we always referred to this vision. With the development of the Hogeweyk, we referred to this vision. Is this normal? No? Then we have to find other solutions. Does technology help us to make this vision work? Then we add it. If not, we don't, etc.
Eloy, since we were talking about technology, the model you showed us didn't seem so high-tech. So how technology can help to sustain your model? I don't know, things that we all see, like sensors that report data, alerts, security stuff in the place, and so on. Where are you, and what do you think you should go in the technology in your specific model?
I totally agree with Nuno that you have to discuss first what problem will be solved. So when we developed the Hogeweyk, we also discussed, do we need cameras everywhere? Because there's a lot of outdoor space, half of the area, and people walk around on their own. And we said, no, why should I need to know where the person is? Because we need to trust the person. So we use in the Hogeweyk technology only during the night, where there are sensors in each room, and it could be acoustic or it could be a sensor. No, there's no CCTV. But the first question is, do we put it on or off? And the starting point is no technology, because people normally sleep during night in their room. Why do I need to know and control everything what's happening during night? And so those questions are important to ask, especially in this time where everybody wants to know where everybody is, where my children are, and you need pictures of how they smile when they are in the daycare. Why do we do these kind of things? So what do you really want to know, need to know, and what's just normal life and the risks of normal life? That you die during the night and you are found at 7, 8, or 10 o'clock in the morning.
In this normal life, you see that some new technological tool will help?
Be part of that.
Or you are
of
not
course.
planning anything for that?
But be critical.
Okay. Walter, I wanted to ask you, we talked quite a lot, I would say, about staff training, empowerment, and so on. So which are the, I would say, skills, soft skill or whatever, that are the most important for staff to be able to implement such a model?
Yeah. I think it's the idea of building relationships and communicating with people, working as teams and all that is just, it always goes back to that. You know, just being a nice person, treating people like human beings, and move away from the task-oriented stuff to the person-oriented things. And getting to know a person deeply. And that's what makes a difference in person-centered care and transforming organizations so many times, is when you really know a person. And that was one of the mistakes I made when I first started. I thought, well, I'm gonna have the staff rotate, because there's just some older people that are a pain in the butt, and so maybe the staff person shouldn't have to deal with them all the time. So maybe we can rotate staff. But I soon learned that consistent assignment of staff, the same staff working with them, building the relationships, noticing differences very quickly, knowing that people like and don't like, is one of the hallmarks of transforming organizations, is that consistent staffing. So, those type things, but I think it always goes back to the relationships.
And Nuno, do you think that robotics, this morning we had a table about robotics, can help to sustain this model, or which is your next step in your case?
I had a very interesting conversation about robotics with Eloy. Because I said to Eloy, I was very motivated after the talk about robotics this morning, and I said, Eloy, I'd love to get all the laundry to be done by robots. So instead of having someone managing the laundry, the bed sheets, and so on, I would have that team member dealing with human beings. And Eloy said, I disagree with you, because to do the laundry is part of the normal life, so we should normalize that. And instead of having a massive laundry, you've got the washing machines in the units in the houses.
Not a unit in a house.
Yes, the house. Now, obviously, it's a different model, the model of care we've got. And I still believe that robotics can be a huge help, and more when we are struggling to get people to look after people. For my generation, when my time comes, I don't know how many people will be able to look after me. To give you an example, we receive visitors from all over the world, and recently we have had many people from China, from Chinese representatives to come and see us, because in the next 10 years they need to build 20 million beds to look after the older community, because the only child policy meant that now the traditional model of the children to look after the parents, that is not possible anymore, because the children might be living the other side of China or somewhere else in the world. So, and that is happening the same with us already. So how can technology help on things like, for example, we are now trialing a new system using artificial intelligence, where there's a camera in the ceiling. It's not filming the person, you only see a blurred shape of someone, that is giving us very interesting insights in terms of the normal sleeping patterns for people. It's giving also insights that we are seeing now about, and we are working on, that's the work I'm doing now, to look at predicting illness, in the sense that, for example, if you have out of a huge sample of people, if you start seeing, for example, changes in the sleep, changes in the respiratory rate, 5 days before someone is formally diagnosed with a urine infection, we can start having alerts that can indicate us that person is going to have a urine infection. The same way with many other things. So there's a huge potential on artificial intelligence and technology on its own that will help us to predict illness so that we can act quicker and give a better quality of life to that person, prevent unnecessary hospital admissions, and save a lot of money to the health system.
I think we are almost approaching the end of the panel. In any case, if maybe there is one or two questions very quickly, we can get a couple of questions. Otherwise,
there's one in there.
We have one question there, and then I think we are probably going to close. Just please, can we do a round of, let's say, very quick closing remarks before taking maybe one or two questions, if we have time? Please, what would be your final or end bottom line message for the audience? What you would say?
We must realize that we are human beings, and that's the starting point of how we organize our lives. We're human beings. Bring back the human in the care.
Yeah, and just do it. Just start doing something. It can be very cheap. The language that we use, what we call things, how we honor people, how we engage people. But just start doing something, and it creates momentum.
And I'd say go back to the basics of life that is the most meaningful for people, and dare to challenge the status quo, dare to challenge the government, dare to challenge the social services and your inspector, if it's for the good of the people you are serving.
Maybe, I think before closing, I think there were a couple of questions.
I will
One there,
walk
very
with the
quick,
mic.
please. Very short question, very short answer, and then we are going to close. I think one there, and that's it.
Yeah, thank you very much for the presentation. I really admire all these initiatives, and I have been following for a long time. But it seems to me that the current trend, at least when we talk about policy, is that the discussion of desinstitutionalization, at least for governments, seems to be invest in integrated care and less and more in home care than let's say home solutions, right? So I want to know what is your take about this, because this is the discussion right now in
Okay.
Spain and many other countries, like in Finland that I come from. It seems like we're getting to that.
Okay. So what's your view?
I totally agree. So I don't promote to build villages or neighborhoods like the Hogeweyk. I promote to humanize the existing places we have, because you can start tomorrow with the change. I totally agree, and you don't need a new structure. So that's what I promote. And for some people, it's really too difficult, or some family members and people and societies, too difficult to stay at home. And for those, you need other places, and those places must still be a human place to live.
Yeah.
So I totally agree that we have to work on societies where people can stay longer at home, where we look after each other again. We lost it in the Netherlands, that we know our neighbors, support the neighbors. So the principle of staying at home and organizing the care there, when needed, I totally agree. But at the other side, those places where people go to must be also nice second best places.
Yeah, agreed. Even in a lot of big cities where there's high rises, where people are living independently, they're creating neighborhoods on their floors and naming their neighborhoods, and people are looking out for each other and interacting just like they would in your community, but they're in a high rise in the middle of a big city.
And I would just say there's a place for both things, for domiciliary care and residential care, but it's very important because the annual expenditure in care is rising every year. This is not sustainable to continue to rise. So we need to be very good at providing government with clear data, clear financial, economical data that demonstrates sustainability, and we haven't been able to do that, and I think that's essential. And I've just provoked Eloy.
I think we have to close, but Eloy,
Yeah.
just...
We can fight over dinner if you want.
No, I don't want to fight. I
right.
totally agree. I agree with
Disagree.
most
I
of
want to disagree with you.
And I want to refer to you,
Yeah.
because what we also must do much more, and you brought up the topic, is talk about death and dying. And accept that we will not live forever, and talk also about how you want to die and when to stop with interventions,
Yeah.
hospital admissions, nursing home admissions.
Yeah.
We have to discuss with societies about death and dying.
Yeah. Yep.
Just to close, a very short, very short story. When just after the pandemic, we wrote an editorial for a geriatric journal with an international panel talking about how should we reshape the nursing homes. And we were a group very much in favor of home care. So let's close all the nursing homes, let's do home care, and that's it. And we invited in the authorship a person who was a normal caregiver of a person with dementia. And she said, okay, your idea is great, but in my situation, it's impossible for me to keep my father at home. So what I want is a nursing home that seems like being a home. So I think the closing idea is that let's recover the idea of the human being. If you can stay home, in your home, it's fine, and we should try to make this possible, but otherwise we need to change the model and go in this direction. Thank you so much. Thank you.
All right. Thank you.
Thank you.